Hello, students, and welcome. Today, we are going to break down a very important topic for your exams and, of course, for your future practice, the drugs that play with the androgen system. We're going to see how we can supplement, block, or even manipulate these really powerful hormones to help our patients. Okay, let's kick things off with a little question to get you thinking. We all know about testosterone, right? But is it the main man everywhere in the body? Well, the short answer is no. The body actually has a much more potent version that it uses for some very specific jobs. So here's our game plan for today. We're going to use a problem-solution approach, just like you would in the clinic. First, we'll understand this hormone's kind of double life. Then we'll look at the problems of having too little and then too much androgen. And finally, we'll get into a very common issue, erectile dysfunction.
Right, so this is the most crucial point to get your head around. Testosterone basically has two forms, and they do different jobs in different parts of the body. If you understand this difference, the rest of the pharmacology will make perfect sense.
Just look at this slide. It lays it all out beautifully. Think of testosterone, on the left, as the manager of all the internal affairs. Suppressing LH, making sure spermatogenesis is happening, building up bone and muscle. But it's dihydrotestosterone, or DHT, on the right, who is like testosterone's much more powerful younger brother. He's the one responsible for the external stuff, forming the external genitalia, making the prostate grow, and yes, unfortunately, also responsible for adult male pattern baldness. Please, you must remember this distinction. Now, let's move to our first clinical problem. What do you do when a patient comes to you and they simply don't have enough androgens? The condition, as you know, is called hypogonadism.
So the most obvious solution, just giving a testosterone tablet, well, unfortunately, it just doesn't work. And the reason is a core pharmacological concept you absolutely have to know for your exams: high first-pass metabolism.
Basically, what happens is this. The tablet gets absorbed, goes straight to the liver, and the liver just inactivates most of it before it even has a chance to work in the rest of the body. So, we have to be clever. We need to find ways to bypass the liver. That's why we use things like long-acting injections of testosterone esters, or maybe transdermal gels. These deliver the hormone directly into the bloodstream, avoiding that whole first-pass problem. But please remember, every drug has two sides. Androgen therapy is incredibly powerful, but it comes with some very significant risks that you, as the doctor, have to manage. Just take a look at this list of issues. In women, it can cause virilization, and things like the deepening of the voice can be permanent. And here's the paradox. In men, giving testosterone can actually cause a low sperm count and shrink the testes, because the body senses the external supply and just shuts down its own production. Then you have other serious things like jaundice with some oral forms, and it can lower your good cholesterol. You have to know all these things before you even think of prescribing. And this is your absolute red flag list. These are the no-go situations. You never, ever give androgens to a patient with prostate or male breast cancer because these cancers are often hormone sensitive. And of course, severe liver or kidney disease are also absolute contraindications. Okay, so we've seen what happens when there's too little androgen. Let's flip the coin and look at the opposite problem, when the androgen effects are too strong. The classic case here is benign hypertrophy of the prostate, or BHP, where the prostate gland just grows too big. The basic funda here is very simple. If we know that DHT is the main culprit making the prostate grow, well, let's just stop the body from making it. And this is exactly what drugs like finasteride and dutasteride do. They inhibit the enzyme 5-alpha reductase, which is responsible for converting testosterone into DHT. And these drugs are actually quite effective. In about half of the patients with BHP, finasteride can reduce the size of the prostate and improve their urinary flow. But, and you must tell your patients this, it's not a quick fix. It can take about 6 months to see the maximum benefit. And as a side note, because it blocks DHT, it's also used to treat male pattern baldness. Same mechanism, totally different application. Let's move to our final clinical problem for today. And it's one you will see very often in your practice: erectile dysfunction. So the basic mechanism is all about blood flow. During sexual arousal, your nerves release nitric oxide. This NO then triggers the production of a messenger molecule called cGMP. Now, cGMP is the hero here. It's the one that tells the smooth muscles in the penile arteries to just relax, allowing blood to rush in and cause an erection. But the body always needs a balance, so it has a natural off switch for this process. There's an enzyme called phosphodiesterase type 5, or PDE5, and its only job is to break down our hero, CGMP. Once CGMP is gone, the erection subsides. And this slide shows perfectly how our drugs work. A drug like sildenafil doesn't create the initial signal. You still need sexual arousal for that to happen. What it does is it blocks the off switch. It blocks that PDE5 enzyme. By blocking the breakdown of CGMP, it lets the CGMP that's already there stick around for much longer, which enhances and prolongs the erection. Please, please listen to me very carefully. For your safety and for your patient's safety, you must remember this. These drugs, sildenafil, tadalafil, vardenafil, are absolutely 100% contraindicated with nitrates, like the ones used for angina. Both cause vasodilation. You give them together, and you can get a catastrophic drop in blood pressure that can be fatal. This is probably the single most important thing to remember from this whole chapter. So, after covering all of this, what's the big picture? What's the take-home message? And the crucial point really is that it's all about balance. Whether we are replacing a deficiency or blocking an effect that's too strong or just enhancing a natural pathway, our goal as clinicians is to use these powerful drugs to gently nudge the body back into its normal, balanced state. And I'll leave you with a final thought, a question for the future. We know that as men get older, their testosterone levels naturally decline. So is giving them testosterone to fight some of the effects of aging a good idea? Is it a medical breakthrough, or is it a risky gamble, considering all the side effects we just discussed? The truth is, the long-term safety data, well, it just isn't there yet. Something for you to think about. Thank you.